of the law always forgets to do that. Okay, so, oops. Okay, so basically, COVID-19 is a disease, right? And I did try to be as thorough as I could be when I was like making this presentation, while also trying to keep it a bit simple, because I know that some of the mechanisms are very complex and I didn't want to like, overwhelm you guys. But if you guys just keep following along, I may not stop in the middle this time to ask questions, to like take questions. I might just take all of them at the end. So, I will go through them though. So let's just like jump right into it. I'm going to open the chat box right here, and I want you guys like, okay, so like, what does one mean by the term pathogenesis? Like when someone says pathogenesis, what does that mean? Right, so pathogenesis is basically the mechanism via which a disease occurs. So it doesn't have to be specific to just like, viral diseases like in COVID-19. It can be any disease. So just the underlying mechanism via which a disease develops, that's called its pathogenesis. I did send some videos over, Abdullah sent some videos over as well. About the immune system. The reason that we did that is because it's very relevant when we talk about COVID-19, and I wanted you guys to have a bit of a, pre-existing idea before this presentation, so that it would be easier for you guys to like, understand it. So talking about the pathogenesis, we first need to know about the immune system. So just going to briefly go over it. Your immune system, it's a wide like system. Like it has not just your B cells and T cells, it's divided into an innate immune system and an adaptive immune system. And the innate immune system is very non-specific. This is important. The reason I'm like focusing on it being non-specific is because it doesn't really discriminate when it's responding to something. It just responds non-discriminatorily, right? And then there's the adaptive immune response, and this is a bit more specialized. This actually takes into account what pathogen it's fighting against when it starts to work. And so when we talk about the immune system, like we have all of these cells, right? So if we talk about the adaptive one first, we have T cells and B cells, and then those T cells are further divided into things like CD4 and CD8. Now, this isn't really anything really different. It's just CD stands for cluster of differentiation. It's just a way to identify that cell. Like in a laboratory, if you're trying to like, find a cell, you would see CD4 cells or CD8 cells. It's just a way to identify what type of cell it is. And CD4 cells are also known as T helper cells. And those T helper cells are further divided into different subsets, right? Those different effector subsets. And each effector subset, like 1 to 17 and the T regulatory cells, they all have their specific functions when they're fighting when they're fighting something. So and then you have your CD8 cells, which I'll show in the next slide. And those CD8 cells are also known as cytotoxic T cells. So you have the T helper cells and you have the cytotoxic T cells, and you also have B cells. And the B cells make up your humoral immunity because they release antibodies. And when you're talking about antibodies, that becomes humoral, right? And the way they interact with each other, the way these cells communicate is via something called cytokines. Cytokines are just molecules. Think of them like messengers between cells, right? So you can divide them. You have things called interleukins. Like over here, you can see that you have something called IL, and you have different types of interleukins. And each interleukin has a function. And you can tell from the name itself that it kind of is like a bridge of communication between different cells. So you have inter, which means between, and leukin, which refers to leukocytes, right? And so it allows one cell to tell another cell like, yo, this is happening, like just take care of it, right? And you have other cytokines as well. You have things like interferons. These are very important when we talk about viral responses. Interferons, they have a few jobs in the body. They stimulate your natural killer cells, and your natural killer cells are a huge part of your innate immune system. They're also lymphocytes, but they're part of the innate immune system, and they're responsible for killing like virus infected cells and cancer cells. And they basically result in like just death of the cell, right? They're kind of like cytotoxic in that sense, but they're again non-specific, whereas cytotoxic T cells would be specific. And so they're important when you talk about a virus, and I'll explain why later. And then you have something called chemokines, and chemokines refers to cytokines that are kind of like homing signals for cells. So for example, like, think of it like a mosquito following a light, right? When there's any kind of injury, you need cells to go to that area of the body. And so these cytokines are kind of just like these like messengers that kind of like home those immune cells to where your body needs them. So that's like, it's important to point these out because we're going to be talking about their functions, and it's a lot easier to talk about the pathogenesis if you know them. Your Th1 subset, these are more, what they do is they stimulate your cytotoxic T cells and they stimulate your macrophages. And so they're involved in, the cellular immune response that you have to primarily intracellular pathogens, the ones that are inside your cell. They're not outside, they're not easily phagocytosed. So your, cytotoxic T cells and macrophages kind of work together to get rid of that pathogen. And that's why you can see that they secrete interferons, which are used as an antiviral response. You have your Th2 cells. Your Th2 cells, they kind of stimulate your humoral response. And the reason they do this is because they release interleukins like interleukin 4 and 5 that cause differentiation of B cells. So under the influence of Th2 cytokines, your B cells become like, they become differentiated and they start producing antibodies. So they make up your humoral response. And your Th17 cells, they're primarily for your extracellular pathogens, things like, fungi and bacteria that aren't within your cells. And they stimulate your neutrophils, which causes like massive inflammation. And then you have your T regulatory cells, and these are important because they moderate your immune response, right? They kind of check the other T cells, and they kind of release cytokines that suppresses an inflammatory response to make sure that it doesn't become too pronounced, or to make sure that there's still tolerance. It doesn't result in autoimmunity, which is when your body starts to, attack itself. And then you have something called antigens. I want to mention those because, so antigen is just any molecule that your body perceives as non-self. So anything, it could be a foreign antigen, it could even be a self-antigen. So foreign antigen would be like, a bacterial protein. It enters, when the bacteria is in your body, your body sees that protein and they're like, wait, this isn't my protein, so that means I'm under attack, so I should do something, right? And then you have self-antigens, which are more in autoimmunity. It's when your own antigens, your body just doesn't recognize them. It just becomes intolerant to its own antigens. And so it's important here, the reason that you can see over here, dendritic cells and CD4 cells, right? So there's something called antigen-presenting cells. It's very self-explanatory. These antigen-presenting cells just take that antigen, they put it onto a receptor called an MHC, and then when your T cells interact with these antigens, in places like your lymph nodes, they start releasing these cytokines, which causes differentiation into all of these effector cells, which release further cytokines, which causes further recruitment of either neutrophils or macrophages or cytotoxic T cells, and all of this together makes up your adaptive immune response. And obviously that also interacts with your innate immune response. They're both happening simultaneously side by side. So that's basically what I've just shown here. You have the antigen, it's being presented. When it's activated, it'll release cytokines, which will cause differentiation of different cells by releasing more cytokines. And then you have your CD8 cells. Your CD8 cells are different. They release enzymes, things like, perforins that cause, and granzymes, and they basically cause the infected cell to die, to just lyse, or to undergo apoptosis. So they're different. Instead of like, recruiting other cells by releasing interleukins, these just directly kill the infected cell. And CD8 cells are formed from Th1 cells because, the Th1 cells release those interferons and stuff, which stimulate these CD8 cells to become active. So, did everyone get this part? Because it is slightly important and relevant when we talk about the next part, which would be the actual pathogenesis. Okay, great. So then we'll move on. So before we go on into the pathogenesis of COVID-19, first I want to talk about the symptoms and the signs. Does anyone know what the difference between a sign and a symptom is? Yeah, you guys are like right. Symptoms are what the patient reports to you. A sign is what is, yeah, exactly, what's evident to the physician. It's what we see in the patient. And signs could be things even like, laboratory findings. It would be signs. It wouldn't be symptoms. So I want to talk about the signs and symptoms first, particularly the symptoms, because, the symptoms determine what the underlying pathology is. You need to know what symptoms are happening to understand what the pathogenic mechanisms underlying them could be. So these are the most common symptoms of COVID-19. These aren't all of the symptoms, but they're the more common ones. I did put a question of this in the quiz as well to see if you guys knew what was more common. So the percentages, they may vary now. This is the statistic that I took from like a week back, so they may have changed, but I just put it there for like, just for you guys to get an idea of how common they are. So the most common by far is fever, and the fever tends to be low grade. High grade fever happens later when you start developing like COVID-19 pneumonia and further inflammatory responses. Cough is one of the really common symptoms as well. And most of the time it's dry. And by dry, I mean there's no sputum or there's no phlegm. If it's productive, which it's possible for it to be productive, but productive generally means that someone's developing, pneumonia-like symptoms. Myalgia, so myalgia refers to muscle pain. Mya refers, like whenever you see my, it refers to like, muscle, and algia refers to pain. So myalgia is just simply muscle pain. And you have fatigue, which are also very common symptoms. Anorexia is a common symptom. A lot of patients with COVID-19, even if they're completely asymptomatic, will report that they have like a lack of appetite. They don't feel like eating. So anorexia, and they wouldn't eat even if they feel like eating, they just don't want to. There's also shortness of breath, the medical term of which is dyspnea, and chest tightness. So this is important because shortness of breath or dyspnea, it's a common symptom, but it's also one of the symptoms that you should watch out for. It's also one of those danger symptoms that they warn you about of like severe disease. And it's been found that, progressive dyspnea, like if you first, you became COVID-19 positive, and then like several days after you actually started showing symptoms for the first time, you develop progressive dyspnea. That's pretty characteristic. Like it happens in a lot of patients with COVID-19. Then there's anosmia. A refers to no, and nosmia means smell. So anosmia means lack of your sense of smell. This is a potential sign of early infection. It's it's well reported, but it's not really something that a lot of people pay attention to. And then there's dysgeusia. So dys refers to abnormal and geusia refers to taste. So anosmia and dysgeusia are like lack of sense of smell and an altered taste. And then headache, which is also a very common symptom of COVID-19. You also have like pretty uncommon symptoms, like, they're like, they can happen, but they're not really common. They happen in a few individuals. So one of them is like pharyngitis, which is just inflammation of the pharynx. To look at the gala kharab ho gaya, that's just pharyngitis. Nasal congestion, and this may even be accompanied by like a runny nose. They might have gastrointestinal symptoms like nausea, vomiting, diarrhea, abdominal discomfort, and mucocutaneous inflammation. Muco refers to your mucous membranes, like, the inside of your mouth and all of that. And cutaneous refers to skin. So just inflammation of your skin and your mucous membranes, that's called mucocutaneous inflammation. And so a lot of people who develop, like not a lot of people, this is pretty rare. Some people develop rashes. They can develop like COVID toes, which are basically like, discolored toes and fingers. They may even develop those. So this is a less common sign. It's more associated with things like Kawasaki-like disease that happens, which we'll talk about. There's conjunctivitis, which is also a less common symptom. Conjunctivitis is just inflammation. It's like colloquially known as pink eye. Obviously, like virals, the eye doesn't become as pink like in bacterial. It's more itchy and wet. But conjunctivitis is this inflammation of the conjunctiva, which is the layer of your eye. And hemoptysis. Hemoptysis is the medical term for coughing up blood. So that is a less common symptom, but it's also one of the signs of like, severe disease. So moving on, there are some signs of severe illness in COVID-19. And these aren't all of the signs of severe illness, but these are the most common ones that one should watch out for. Shortness of breath, dyspnea or chest pain. Cyanosis. Cyanosis refers to blue, right? So your body becoming blue, it means you're becoming cyanotic. So if your nose or your tongue or your fingers or toes, they start to become blue, that's known as cyanosis. And this generally means that hypoxia is happening. And hypoxia is from oxygen. It just basically means less oxygen, hypoxia, right? So there's less oxygen going to where your body needs that oxygen. Altered mental status. And by this, I mean, there could be confusion. There could be like, drowsiness, a lot of lethargy. So if someone starts, seeming like they're not all there in the head and they start seeming really confused or lethargic, then that would be like altered mental status. And they may even like start forgetting things and become like really out of it. And then again, hemoptysis, which is just coughing up blood. So if these symptoms start to appear, or signs in the case of cyanosis, then it's important to seek medical care. And so that's why they recommend that whoever has COVID-19, they should monitor their symptoms, even if they're asymptomatic. They recommend that you should do like twice daily temperature checks, and they recommend that you monitor your symptoms. And if any of these signs or symptoms start to appear, you seek medical care urgently. So now that we've talked about the common, the less common, and the severe symptoms of COVID-19, we're going to talk about the pathogenesis underlying, particularly COVID-19 pneumonia, which is the most common severe condition associated with COVID-19. So we talked about all of those, so hopefully it'll be a lot easier when we're talking about this. The COVID-19 pneumonia, the reason that it causes such severe disease is because of your body's immune response to the virus. So initially there is some like viral infection. Obviously the virus is also causing damage, but the body's immune response to the virus is what predominantly results in such severe disease. I talked about antigen presentation, those foreign viral particles. Your body presents them on these things called MHCs, and then these stimulate your CD4 cells, your CD8 cells, which are your cytotoxic and your T helper cells. And then those release cytokines, or they release enzymes in case of cytotoxic T cells, which result in apoptosis, class switching. And so the B cells, class switching just refers to when B cells start making a different type of antibody. And this you would think that this is good, right? Because there's apoptosis, so the virus infected cells are dying, and there's class switching, which means that antibodies are starting to be formed, so that would give immunity. But then that's where the innate immunity comes in. The innate immunity is basically very non-specific. You have, with every pathogen, there will be things that are associated with that pathogen, these molecular patterns, so to speak. And these are called pathogen-associated molecular patterns, or PAMPs. And the innate immune cells, like your neutrophils and your natural killer cells and all of these, they have something called toll-like receptors, which are just receptors that recognize these pathogen-associated molecular patterns. And so when they recognize it, there's like a huge downstream change in like, responses within the cell, which results in the activation of specific transcription factors, which are basically just factors that increase the transcription of certain genes. And so some of these, for example, include like nuclear factor kappa B, which is very important when we talk about the immune system. And so when these transcription factors are activated, because they increase transcription of certain genes, they upregulate the transcription and thus the translation and the formation of multiple pro-inflammatory cytokines, as well as and chemokines. Chemokines are technically under cytokines, but they're not always pro-inflammatory. So pro-inflammatory cytokines include things like interleukin 1, interleukin 6, your interferons, interleukin 18, and all of these and also not just pro-inflammatory cytokines, but also like colony stimulating factors, which are just these molecules that cause further that promote the formation and differentiation of things like your macrophages. So all of that collectively results in a cytokine storm. There's too many of these pro-inflammatory cytokines, and these cytokines are further activating more cells. And by further activating more immune cells, there's even more pro-inflammatory cytokines. So it results in this kind of positive feedback loop, which results in eventual immunopathogenic injury to your lungs, which is basically your body. It's basically just that your body starts to damage itself. Your own immune cells start damaging your lung tissue. And because of that, a lot of people the most common complication is acute respiratory distress syndrome. So your body basically just goes into respiratory distress. Then there's not enough oxygen because there's lack of, that oxygen transferring interface in your lungs. And because of that, there's less oxygen in your body. And because of less oxygen in your body, there's less oxygen going to your organs. And your organs need oxygen. The cells in your organs need oxygen, or they start to die or necrose. And so if there's less oxygen going to your organs, they start to die, and you end up in multi-organ failure. And so that is the culmination of untreated COVID-19 pneumonia if it gets really severe. And the reason that this is so potentiated, it's proposed based on what we know from SARS-CoV-1, is that SARS-CoV-2, it may evade type 1 interferons. I mentioned before, interferons important when we talk about viruses. Interferons are kind of like those molecules that, your infected cells release them as well. And they're kind of like, signals to the uninfected cells. Then they're like, yo, listen, I'm infected and I'm going to die. But I'm just warning you that there's a virus here. So those uninfected cells then change themselves a bit. Like they downregulate receptors that the virus can use for entry. They alter the transcription of genes that results in, just making them a bit more it's kind of like someone getting ready for war. So it just kind of like primes them. And so SARS-CoV-2 actually evades this response. And because of that, there's just unchecked replication. So there's a lot of the viral particles being formed, and the more viral particles are formed, the more there's activation of your innate and your adaptive immune system. So it just results in more release of these cytokines. And so this is we know that it causes acute respiratory distress, because when we do autopsies on patients who have who have died from COVID-19 pneumonia, their lungs, they show diffuse alveolar damage, which is very characteristic of acute respiratory distress syndrome. Beyond just this is just a diagram of the positive feedback loop. I've explained it. You don't really need, I'll give the presentation later so you guys can go through it, but for the sake of time, I'm just going to move on. So beyond just affecting your, lungs, it has a lot of other effects on a lot of other systems in the body as well. And some of the more pronounced ones are in the cardiovascular system. Abdullah talked about the risk factors in his previous presentation, and the comorbidity or the disease that is most associated with a higher fatality and a worse outcome in severe disease in COVID-19 is pre-existing cardiovascular disease. And so patients who have COVID-19 and they have cardiovascular disease, they can develop arrhythmias, which are result means no, and rhythmia means rhythm, right? So arrhythmia, no rhythm in the heart, or dysrhythmia, which is abnormal rhythm of the heart. It can cause myocardial injury. The myo refers to muscle and cardium refers to your heart. So myocardial injury is just injury to your myocardium or to the muscle in your heart. It can cause inflammation of that, which is called myocarditis. And it can cause acute MI, which is myocardial infarction, colloquially known as heart attack. And, it can cause heart failure. It can actually infect the endothelium of your vessels. Your endothelium is just a layer that you find in all of your blood vessels. And so it can infect, and we talked about how, ACE2 receptors are present in a lot of different cells. Some of the cells that they're present on include endothelial cells. So the virus can actually invade into your blood, into your blood vessels and damage those blood vessels and cause endotheliitis. And it can also cause something known as VTE, venous thromboembolism. This is very characteristic. A lot of people who die from COVID-19 die from something called a pulmonary embolism. I'll talk a bit about this, but a venous thromboembolism is basically just a blood clot. Okay, that's just what it's known as colloquially. And so thrombosis in itself doesn't just always occur from one thing. Beyond just the upregulation of cytokines, whenever there is an acute immune response in the body, it results in the upregulation of proteins called acute phase reactants or acute phase proteins. And these include coagulation factors. But it's been noted that in COVID-19, there is massive upregulation of, coagulation factors. It results in hypercoagulability. Hyper just means to more, and coagulability means to like a coagulable state. So they have actually termed this COVID-19 associated coagulopathy because it's so pronounced that it's been seen in so many people that they've actually given it a name now. And this is also coupled with DIC. This is known as disseminated intravascular coagulation. This happens more in shock, when there's fulminant coagulopathy. Fulminant means to anything that happens very severely and very suddenly. And this happens mostly in things like septic shock, but it is seen in like COVID-19 as well. So all of this coupled together, like your hypercoagulable state due to COVID-19, your DIC, that results in it results in like a lot of hypercoagulability. And that in itself doesn't always cause stroke or venous thromboembolism or anything like that. But there's something called Virchow's triad. This is something that they teach you like when you start medical school and you're just like, why are they teaching us this? But it's really relevant. So there's a three-way thing that results in venous thromboembolism or thrombosis. There has to be hypercoagulability, and then there has to be stasis, and there has to be injury to the blood vessels. So stasis just refers to lack of movement of blood flow, the pooling of blood. The reason that stasis causes hypercoagulability and can cause thrombus is because, when your blood isn't flowing, all of those coagulation factors and your clotting factors and your platelets, they kind of start to just, pool in one place, and they can end up forming like a thrombus, which is a clot, which consists of like platelets and RBCs, your red blood cells, and all of these coagulation factors and like fibrin, and they're just like put together and they make a little clot. And that's why people who are in hospitals are more likely to develop this, venous thromboembolism. It's because they're just lying in bed, they're not moving around, there's stasis of blood. And because of that, they develop it. That's why people who are like, stroke patients, for example, they have to, get all the physiotherapy done. It's not just to prevent accumulation of fluid, in the extracellular space in the tissues, but it's also to prevent this thrombus from forming. And then there's, endothelial injury. Whenever you have injury, like if you get a cut on your hand, you're going to see that after a while, it's going to start forming a scab. After the scab forms, it'll heal. So that's because of your clotting factors, your platelets, there's an entire coagulation cascade involved in it. And so what happens when you have endothelial injury is that all of these clotting factors, when they see, oh God, there's like an injury in my vessel, they start to accumulate there and they start trying to plug it. And so all of these put together, that's known as the virtuous triad. And all these put together can result in formation of a thrombus. And then this thrombus, it can get dislodged from the vessel. It can go into the venous circulation, and it can go and get lodged in your pulmonary vessels, the vessels that go to your lungs. And when that happens, it can cause something, and that's known as pulmonary embolism. And it'll result in like massive hemorrhage. The person can start coughing up blood. The person will start going into shock because there won't be enough oxygen being delivered to their tissues as well. And there's in autopsies of people who have died from COVID have shown that there's a higher than normal incidence of deaths due to pulmonary embolisms. Beyond just that, there's also other cardiac manifestations. So you don't necessarily have to be symptomatic or have the symptoms of a cardiovascular disease in order to develop these complications. The complications of COVID-19, the cardiovascular ones, they can happen in people who have asymptomatic cardiovascular conditions as well. That is, they are not showing symptoms of any cardiovascular disease before they get COVID. And this is because whenever you have inflammation, you have destabilization of pre-existing conditions, even if they were asymptomatic. There's something known as atherosclerosis. It's just the deposition of lipids, cholesterol in your vessels. This inflammation can cause rupture of these atherosclerotic plaques. And for example, if these were, let's say in your heart vessels, it can result in things like myocardial infarction. So it can even destabilize pre-existing asymptomatic conditions, which is why, it tends to be so, kind of like, so it takes people by surprise sometimes because, there might be someone who may be completely healthy in appearance, but they can develop things like MI when they develop COVID-19. So this is just the virtuous triad of thrombosis, which is basically, the formation of a thrombus and then its a subsequent dissemination in the body. And so you can see that there's vessel wall injury, there's stasis of blood, there's hypercoagulability, and there are different conditions associated with it. But in COVID-19, it's because of inflammation and damage to the vessel walls. I talked about acute phase proteins. The reason I put this up is because I really want you guys to look at some of the things. Particularly, I want you guys to look at fibrinogen. I'll tell you why when we talk about labs, because this is a very important lab finding that we have. Acute phase proteins, they're produced mainly by the liver, and they're just proteins whose serum concentrations, that is their concentration in the blood, they become they either increase or decrease. They basically change very pronouncedly or very significantly during inflammation. And so you have positive acute phase proteins like, your C-reactive protein and your fibrinogen, and you have negative ones. Positive ones, they're the ones whose presence increases during inflammation, and negative ones are the ones whose presence decreases during inflammation. So all of the positive acute phase proteins will be elevated. Fibrinogen will be elevated, and fibrin will also be elevated. Now, fibrinogen and fibrin, they form clots, and then when the fibrin kind of degrades, it breaks down, it produces something known as D-dimers, which are just degradation products of fibrin. And I point this out because those are very markedly increased when we talk about COVID-19, and they're also associated with a higher, they're a very early sensitive marker of severe disease. And it's important to note that there's a reason that these increase, right? Like C-reactive protein, it doesn't just increase anything. It increases because, it promotes phagocytosis. It activates complement, and complement is just a pathway in your body. They're part of your innate immune system that help, your body kind of kill and phagocytose and cause damage and cause, the infected cells to kind of rupture. So they have a lot of like, uses. And the reason that the negative ones are decreased is also important because, albumin, for example, you don't want to produce a protein, you don't want to use your amino acids to produce non-essential proteins when you're, battling an infection. So, instead those amino acids, they go into making things like C-reactive protein and fibrinogen, stuff that you need. The reason that fibrinogen is increased is so that, it can fix endothelial damage. But obviously when it becomes too pronounced, it can be counterintuitive and it can result in stroke or like, formation of a thrombus, and therefore like pulmonary embolism. And the reason I bring this up as well is the reason it's so pronounced when we're talking about, the reason that these acute phase reactants are so highly elevated, particularly in COVID-19, is because of something called interleukin-6. I mentioned that interleukins communicate between cells. Interleukins, particularly interleukin-6, it causes massive upregulation of these positive acute phase proteins. It can cause too much fibrin and fibrinogen to be formed. And so that's why when we have a cytokine storm and elevation of things like interleukin-6, that means that there's likely to be greater mortality associated with it. And that's why one of the treatments that people are discussing for COVID-19 and are looking into as like an adjuvant, and by adjuvant I mean kind of like a therapy to kind of just enhance the primary therapy, is interleukin-6 inhibitors, monoclonal antibodies against the interleukin-6 receptors like tocilizumab. So I just put all of it together, the risks, the complications. I'll again send this presentation to you guys. You don't have to read it right now, but I thought it was a really good summary. And then neurological. I mentioned that, there are receptors everywhere and that it shows neurotropism, which is that it has a predilection for going to the brain and to the nervous tissue. And so because of its neurotropism, it can result in stroke. It can normally, when you have arterial thrombi, those result in stroke. Whereas if you have venous thrombi, like the one we talked about previously, those generally tend to result in pulmonary embolisms. So one can develop strokes. They can develop encephalitis, which is just inflammation of the brain. They can and due to encephalitis, they can develop seizures and altered mental status. Dizziness, headache, vagera are also neurological symptoms, but they're not really very severe symptoms. Anosmia, dysgeusia, and something known as GBS has been described as well. GBS is associated with a lot of viral infections, also with a lot of bacterial infections. It's associated with it's like a lot, it has an association with Campylobacter, it has an association with Mycoplasma, it's even associated with things like varicella zoster. And it's basically called Guillain-Barré. It's just like an ascending paralysis. So first you can't move your toes, then your legs, and eventually as it ascends and reaches the diaphragm and the muscles involved in respiration, you could end up it could prevent you from breathing. And then anosmia. So studies have found that there's actually a lot of axonal transport of the virus that causes COVID-19, SARS-CoV-2, from the olfactory bulb, which is just kind of at the top part of your nose where all of your olfactory cells, olfactory refers to smell. So the nerve that, is involved in smell, it has all these synapses over there. So there's studies that found that it can go to the brain from the olfactory bulb. And then there's renal. Your renal tissue, it's very sensitive. If it's constantly filtering your blood. If there's even a slight decrease in blood going to the renal parenchyma or to the renal tissue, it can result in acute kidney injury. And acute kidney injury can be reversible. Most of the time, if you remove the cause of the injury, it is reversible. But if it's sustained and prolonged and there's lack of oxygen delivery, then it can result in massive kidney damage and could potentially even be irreversible. So in acute kidney injury, so if you're talking about labs, if you do a urine DR, which is a urine detailed report of someone who has COVID-19, particularly severe COVID-19, or hospitalized, it's very common to see proteinuria. Urea means presence in blood, presence in your urine, and protein just refers to your, protein. So proteinuria is just the presence of proteins in your urine. Hematuria is the presence of blood in your urine. That is RBCs, sorry. WBCs would be pyuria. And it occurs with majority of the patients that are hospitalized with COVID-19. So it has a very early and a very temporal relationship with the respiratory failure associated with COVID-19. And so this is not the only reason, but it's one of the reasons why when one is doing a CT scan, which is computed tomography, of a patient who has COVID-19, you wouldn't want to give them contrast. Like, there are multiple reasons, but one of the reasons why, we don't give contrast in patients, particularly in severe COVID-19, when doing scans, is because of the kidney injury that they may have. Because that can be nephrotoxic, as in it could be toxic to your kidneys. Contrast is just an agent that someone's given. They take it and it just enhances certain things. Like it just becomes radiographically enhanced. So it has indications. It has contraindications. But in COVID-19, it's preferred to not give contrast when doing a CT. And then there's the last slide in clinical features and pathogenesis is the Kawasaki-like disease that is happening in children. It's a very, very rare thing. In fact, there's only a handful of cases that have been described, and most of them are in Europe, particularly in places like Italy and on the east coast of North America. So these are the two places where it's been described the most so far. It's not a common thing by any means. It's pretty rare, and the names that it's given, depending on which continent you're at, they call it different things. In the US, they call it multi-system inflammatory syndrome. In like the UK, they call it pediatric multi-system inflammatory syndrome. The reason that a lot of people just refer to it as like Kawasaki-like disease because it resembles Kawasaki disease a lot. Now, the underlying pathogenesis of Kawasaki disease, we don't know it. The underlying pathogenesis of this, we don't know it either. It's unclear. There are a lot of theories, but there's no definitive thing that we know about it so far. And so it's just characterized by vasculitis, which is inflammation of your vasculature with fever. And there are all of these things that you might see, like because of the vasculitis, you might see like, palpable rashes, like those COVID toes and everything. And, mucocutaneous manifestations, like a strawberry kind of like very like large inflamed tongue. But like, I'm not gonna like read all of this out. You can like go through when I send over the presentation. And then with that, we're done with like, the clinical features and the pathogenesis. I'm just gonna quickly take some of the questions that were asked during the section so that we can move on. So most COVID-19 patients are bradycardic. So not necessarily. Like it depends. Generally, like if they start going into shock or something, they can actually become tachycardic. It's very dependent from patient to patient. Can pulmonary embolism occur without shortness of breath or dyspnea? I don't think I've ever heard of a case of someone who developed pulmonary embolism and didn't develop shortness of breath or dyspnea. Shortness of breath and dyspnea doesn't always mean that there's pulmonary embolism, but if you have a pulmonary embolism, you're very likely to present with shortness of breath or dyspnea. Varicose veins are just like when veins dilate and they're unable to kind of, so your veins have these kind of valves that allow, black flow. They're not actively pumping like your arteries. And so when those valves become non-functional, your vein kind of dilates, it pulls blood there. And so it can cause like stasis of the blood. And yeah, okay. So moving on to your labs. So I want to ask a question. You guys can see it on the screen as well. Do abnormal labs always mean that a patient should be admitted to a hospital? So I've gotten like two varying answers. One person said yes, one person said no. Two people said no. So it's pretty varied. No. The answer is no. Not everyone who has abnormal labs has to be admitted. So this is one thing that's very important in medicine. You're not going to treat labs. You're not going to treat the disease. You're trying to treat the patient. Okay. So if they have so it's very likely that if you have any kind of viral infection, for example, like let's say gala kharab ho gaya and it's a viral, pharyngitis kind of picture, if you do a CBC or a complete blood count, you'll see that there will be skewed lab findings. That doesn't always necessarily mean that one should be admitted to a hospital. It depends on the severity of the laboratory findings and what laboratory findings are skewed. For example, if it's something like massively elevated D dimers and massive cytokine storm, then you'd say, okay, you know what, I should admit this patient. But if it's something minor like, lymphopenia, which is a very common lab finding in, people who have COVID-19, then it depends. Then you really don't have to admit them, especially in the setting of a pandemic where you have such a vast majority of patients and you don't really have enough hospital beds and you don't really have enough healthcare professionals to actually care for them. It's important that you don't just admit everyone who comes in. What do you mean by what do you mean false negatives and false positives? I don't really understand that question. Abnormal labs, by abnormal labs I just meant like anything, like any skewed lab, anything that's not normal, like when you're talking about like a CBC. So it could be something very minor like lymphopenia, or it could be something like very major like D dimers. But one single abnormal lab does not mean that a patient has to be admitted to a hospital. If they have very severely skewed labs, but they're completely asymptomatic, they're completely fine, they don't show anything, you can monitor them, just keep repeating their lab findings, and if they worsen, then you could maybe consider it. But you have to look at the holistic picture overall. You have to look at the history, the signs, the symptoms, the examination findings, their lab values, their imaging results, and collectively make that decision for each patient. It's not really black and white. So talking about the lab findings, there's lymphopenia. Lympho refers to lymphocytes, it includes your B cells, your T cells, and penia refers to low presence in blood. So lymphopenia is just like low lymphocytes in your blood. Now this is odd because mostly if you have viral infections, you would assume, viral infections, they're predominantly, they're characterized by high lymphocytes. Like if you see any kind of viral picture, you would have lymphocytosis, which is high lymphocytes in your blood. But it's been seen that lymphopenia is more pronounced. In fact, it's the major blood finding, major CBC finding in a person who has COVID-19. And there's a lot of theories as to why. A lot of people, that have been proposed. Some people believe that maybe there's impaired production of new lymphocytes. Some people propose that maybe because they're viral infected, there may be increased destruction of these lymphocytes. And then one very common theory, which is also very likely, is redistribution. So I mentioned that whenever you get any kind of cut, you have all of that inflammation that happens, which is characterized by the redness, the pain, the swelling, the lack of movement, and all of that. And that an inflammation happens due to your immune system. Your cells are causing that inflammation. So you would think, okay, so our cells, they're in our intravascular compartment, which is they're in our blood. So how do they get to that tissue to cause that inflammation? So that's something known as extravasation. It's just the movement of those cells that cause inflammation from the intravascular compartment, from the blood, to your tissues or to your extravascular compartment. And when we're doing a CBC, when we're taking blood, we're taking it out of our venous blood, right? We're doing a venipuncture, and that's how we're collecting it. So if those cells have been kind of redistributed to the tissues, we're not really going to detect them. So that doesn't mean that the total number of cells in the body, or the total number of lymphocytes in this case in the body, are decreased. It could just mean that there's just been greater distribution of those cells to the tissues, which is why you can detect their presence in your blood. and it can give like kind of like a misleading lymphopenia, but we don't really know. There's still like there's a lot of theories about this. There's also elevated liver enzymes, particularly the transaminases, things like ALT, AST. They're very elevated generally in things like hepatitis, but it's been found that they're elevated in COVID-19 as well. Elevated lactate dehydrogenase. Lactate dehydrogenase is associated with aerobic metabolism. If the cells aren't getting enough, oxygen, it may be elevated. And elevated inflammatory markers, those positive acute phase reactants I talked about, like CRP, which is the C-reactive protein, fibrin, fibrinogen, serum amyloid A, all the complement. Procalcitonin may also be elevated. Even like cardiac enzymes like troponin I, they can be elevated as well. And you have D-dimers that can also be elevated. D-dimers are those degradation products that I talked about. And it's important when we talk about D-dimers because studies, like a huge meta-analysis that was done, found that if you have D-dimer levels greater than 1 microgram per milliliter, that can be used to identify patients who have a poor prognosis early on, because it's indicating that these people are going into hypercoagulability. And you'd have other coagulation abnormalities as well, things like, increased platelets and things like, increased fibrinogen, your prothrombin time, your, in protein C, all of those things, they will be increased. But the most common finding that is associated with a poor prognosis is elevated D-dimers. And that's an important finding. Even interleukin-6, but D-dimers are very well known at the moment. And this is interesting. So I attended this kind of like webinar with Dr. William Muller, and he proposed, there's a lot of like anecdotal kind of like eccentric case reports of patients who have COVID-19. And it's been shown that people who have blood group A are more likely to develop coagulopathy associated with COVID-19. And so there is a link there. Your blood group antigens, your A, your B, your O antigens that kind of determine what your blood group are, they also determine the levels of this protein called the von Willebrand factor. And this von Willebrand factor, if it's elevated, that results in hypercoagulability. It causes increased platelet aggregation, and all that coagulation. So so it's been observed. Obviously, this isn't like, this is just his theory on it. Like, elevated, that's why blood group A people have higher chance of developing severe cardiovascular complications of COVID-19, but obviously more research has to be done on it. This was a great paper. It kind of just reviewed all of the lab findings of people who had COVID-19, and you can see that, you have the lymphopenia. Thrombocytopenia, again, is because even though there's increased platelets, thrombocytopenia refers to platelet levels. There's increased coagulation, so they may seem decreased because they're clotting so much. Leukopenia, increased CRP, D-dimers, LDH, prothrombin time, and all of your ALT, AST, which are your transaminases, your liver enzymes. So I'll send this over as well. And then, so with that, we're done with our labs. If anyone has any questions regarding lab findings, like they can ask them, and then we'll move on to imaging, which is a very short part, and then we'll be done. Okay, so no one asked anything, so I'm just gonna move on to imaging. So I'm gonna ask the same question. If you have abnormal imaging, does that mean that you should admit a patient to the hospital? Yeah, exactly, no. It's very likely, especially early on, that people who are developing COVID-19 pneumonia, even they can develop abnormal imaging. They could have a weird CT look, a weird looking CT scan and whatever, but that doesn't necessarily mean they have to be admitted. You have to look at their symptoms. Like, for example, if they have those findings on a CT scan or on an X-ray, and then they start developing lack of oxygen, their oxygen saturation starts decreasing, they start developing cyanosis or shortness of breath, then you'd want to admit them. But again, you're not treating their laboratory findings or their imaging findings, you're treating the patient and their symptoms. So it doesn't necessarily always warrant admission into a hospital. So CT scans are more sensitive than chest X-rays. I'm talking specifically about chest imaging. I'm not talking about things like, like the venous thromboembolisms or anything like that. So CT scans, they are being used. A lot of places actually use them as screening. In China, in a lot of places in Europe, people use CT scans for screening. Now this is kind of like, controversial. Some people are like, you should use portable chest X-rays because, there's less cross-contamination and, there's ease, you don't have to remove that X-ray from the ward. But some people, like people who can afford it, like facilities that can afford it, do have dedicated CT scanners that they use as a screening tool for people with COVID-19. And CT scans are more sensitive than chest X-rays. Specifically early on in the disease, you may have completely normal chest X-ray findings, but your CT scan may show like a few like hyperdense regions. And so it's a very useful screening tool. Chest X-rays, they're generally normal in early disease and mild disease. And then as it progresses, you'll see like bilateral infiltrations and, especially in the periphery and then the lower lung zones. It's very characteristic. CT scans, there are a lot of findings that you can see on CT scans. The ones that have the highest discriminatory value, the ones that happen with most COVID-19 patients and have been shown by a lot of meta-analyses to have the highest discriminatory value are something called GGOs, which are ground glass opacifications. And these tend to be bilateral, subpleural, as in they're under the pleura, which is like a membrane that covers the lungs, and they're peripheral. And there's also bronchovascular thickening within these lesions or these GGOs, and there's peripheral distribution. There's other findings, things like crazy paving and traction bronchiectasis. I'm not going to go into that because, quite frankly, even though I have had my radiology rotation and I have been looking at this stuff in the wards for 2 years at this point, I still don't understand most of it. So what's better, CT or CXR? CT for sure, it's more sensitive. You can pick up the findings early on, but there are two downsides. One, it's harder to decontaminate, and two, it's more expensive, not just for the hospital, but also for the patient. Over here, you can see a chest X-ray on the left and a CT scan on the right. So on the chest X-ray, you can see that particularly in the right upper lobe and in the left lower zone, right? So in those two areas, you can see that there's very characteristic opacification. There's airspace shadowing. It seems a bit more hazy compared to the rest of, the lung field. And so those are basically those basically represent your ground glass opacifications on a chest X-ray. And then on the right, you can see the CT scan. And in the CT scan, you can see that there's bilateral ground glass opacifications, and that they're very characteristically present on in the posterior aspect. So I'll try circling it. I don't know how to do. So over here, you can see they're bilateral and they're throughout, but they're very pronounced in the posterior part. And so one thing that I do want to bring up is that they are sensitive, imaging results, they're sensitive, but they're not specific. So all of these findings that you're seeing on a CXR, that you're seeing on a CT scan, they happen in COVID-19, but they don't only happen in COVID-19. So when you're treating a patient, it's important not just to look at their imaging results. Anyone could look at the CT or at the X-ray and say, okay, oh, this is definitely COVID-19, but it could be anything else. It could be another infection that's not COVID-19. A lot of viral pneumonias can present with bilateral infiltrates. A lot of fungal infections can cause ground glass opacification. There's drugs that can result in these findings due to, pulmonary toxicity. So it's important not just to look at the imaging results, but to look at the patient holistically, look at their history, their examination, their lab findings, their imaging, and that's how you come to a diagnosis and treat the patient. You don't, so it is sensitive, you know, it picks it up. You would have findings on it early on in the disease, but it's not specific. The findings don't always mean that the patient has COVID-19. And so the last thing that I'm going to talk about is putting it together. So with any disease, it's always important to have kind of like a staging model, or kind of like, you know, a way to characterize how severe it is. And we need this because it helps us determine what kind of treatment to get at what point. So there was a paper, and it proposed a 3-stage classification system for COVID-19. And so what they did is they took they did a huge analysis, and they put together all of the early findings, the intermediate findings, the late findings, along with all of the clinical signs, the symptoms, and they kind of like put it together in like a 3-stage model with increasing severity. So they characterized it into stage 1, 2, and 3, with 1 being early infection, and which is very mild, and 3 being a very severe systemic hyperinflammation. And so you can see that initially in stage 1, the virus has just been inoculated, you know, it's just entered the body, and it's starting to massively like replicate. It's starting to cause all of those constitutional symptoms which happen whenever you have an infection, like a fever, and because it's in the lungs, you know, it can cause dry cough. Diarrhea is a less common finding, but it can happen, and things like headache. And so, like, you know, malaise and all of that stuff, it's starting to happen. Your SARS-CoV-2 is starting to establish itself in your body. And so this is the viral response phase, where you have like a really high viral load, especially in the beginning, because of the massive replication that's happening. And over here, the main things that you're likely to find on labs, you might find lymphopenia, but it may be very, very mild lymphopenia, and it may be just lymphopenia without any other deficits. If you have a predilection towards going into, a poor prognosis, you may even have elevated D-dimers. I mentioned that it's early on that it is a very sensitive indicator of a bad prognosis in COVID-19 early on, and even LDH. So LDH is also associated with like a worse prognosis and increased prothrombin time, if you potentially, but the most consistent finding in this stage would be lymphopenia. And it may not even be severe, and it may not even be accompanied by anything else. So fever can be considered both a sign and a symptom. When you have a fever, sometimes people can feel it. You know, you can develop like cold chills, sweating and stuff. So that is it is technically also like a symptom. It's also a sign. And no, at the moment, this isn't classified according to days. It's just a proposal of like a model. They haven't characterized it by time. We really don't have a lot of research in order to be able to say, okay, this is when you will develop this stage of the disease. And then there is stage 2. Now, stage 2 is divided into 2A and 2B. 2A is without hypoxia, which is without a deficit of oxygen, and stage 2B is with hypoxia. And in this stage, what's starting to happen is that the virus has established itself within the lungs. You know, there's established pulmonary disease and consistent viral replication that's happening at a constant rate, and that's causing localized inflammation within the lungs. And in this stage, the patient develops viral pneumonia. And so this viral pneumonia is at this point, you would see increasing lymphocytopenia. You may start to see elevated liver enzymes. You may even start to see some markers of systemic inflammation, but they're not very pronounced yet. And you can develop low oxygen saturation. That would be to be like with hypoxia. And shortness of breath may develop at this point as well. And at this point, if you do imaging, you would find abnormal imaging. You would find those opacifications on a CT scan, and potentially even on an X-ray at this point. And then there's stage 3. Stage 3, not everyone goes into it. But stage 3 is the hyperinflammation phase, that cytokine storm that we were talking about. That is stage 3. So in stage 3, what happens is you have massive extrapulmonary systemic inflammation. And what's happening is that's causing all of these cells to just attack the lungs, and you're going to develop things like acute respiratory distress syndrome and shock, and it can result in cardiac failure and cardiovascular collapse, and that can eventually result in multi-organ dysfunction. And so over here you would also have like those elevated coagulation factors, so you can end up with like a hypercoagulable state. Things like pulmonary embolism can happen over here as well, and this is predominantly because of your host inflammatory response. It's not the virus that is causing this, it's your own body, your own immune cells that are attacking your tissues, not because of autoimmunity but because of the infection. And over here, you're likely to see elevation in all of those markers of systemic inflammation, like your interleukins and your D-dimers and your ferritin and your C-reactive protein. And all of these things will be very, very massively increased. And so when we're talking about the treatment in our next tutorial, I will bring back this diagram and I will show the potential therapies at each stage that can be used as well. But for now, that concludes today's tutorial. And if anyone has any questions, now would be the time to ask. So varicose veins in general, not specific to COVID, they're just generally a risk factor for hypercoagulability. But if you have simple varicose veins, I mentioned that, just one of the three isn't often sufficient enough to cause thrombosis, right? You need to have at least two of them to have like a pronounced one. Obviously one can, but that would be very rare. It's not common. That's why it's called a triad of things. So if you have varicose veins and they're asymptomatic and you don't really have any kind of problem with them, then it shouldn't cause thrombosis. If you develop COVID-19 and you have varicose veins, there may be an increased risk, but we don't really know enough to quantify how increased that risk would be. It's possible, but again, it's not something that we know at the moment because there's still so much we don't know. Does everyone enter stage 2? No, not everyone enters stage 2. And some people, they're able to clear the virus from their system before, they seroconvert faster. They may be completely asymptomatic. Not everyone develops COVID-19 pneumonia. That's why we have asymptomatic infection. Stage 2 means that there's pulmonary involvement. The person is developing pneumonia. Is it possible to do a CT scan and notice hazy lung opacity, bilateral nodularity in a patient who claims that he is not experiencing dyspnea? Yeah, exactly. So that's what I was saying. Not everyone who has findings on a lab or an imaging thing would necessarily be symptomatic. It's very it's very common that people, they just get screened. They get that's why CT scans are being used for screening. Screening is essentially when you're just testing people. The people can be either symptomatic or asymptomatic. So it is possible for people who are asymptomatic to have abnormal imaging and lab findings. How does one know if they're asymptomatic for COVID? Really the only way you would know is to get the diagnostic tests, like your RT-PCR, to do your serology, or serology would indicate that you've developed antibodies, so you don't have the virus, you've recovered from it. But you would have to do a diagnostic test for that, which we're going to talk about in the next tutorial. For COVID-19 positive patients, will there always be some sign on the CXR? No, not necessarily. A lot of people don't develop any kind of findings on their CXR. And the thing is, CXR, like I mentioned, in early disease, it's really just not that sensitive. Like you would maybe find like a normal chest x-ray. It's not until later when you start developing the pneumonia picture that you would start finding things on a CXR. So it is possible that patients who have COVID-19 don't develop a finding on their CXR. They may be completely asymptomatic. They may not even develop any finding. They may just have minor lymphopenia. It varies from patient to patient. You can't generalize lab findings or CT findings or CXR findings to every patient. It would vary. That's why for each patient you have to make sure that you have a thorough history, background, everything. You mentioned GBS to be a probable neurologic symptom. How in this case the WBCs attack the peripheral nerves. So GBS isn't thought to be due to like it's not it's not a symptom per se, it's a syndrome, and it's associated with a lot of things, and I'm not going to go into a lot of details on it, but it's just it's a potential complication that can happen in COVID-19, where people develop autoimmunity. So that is post-infectious state में their immune cells, they start attacking their own, in the post-infectious state, they start attacking their own cells. And that basically, okay, sorry, I was like muting someone. Yeah, so in the post-infectious state, they start to attack their own immune cells. They start attacking the myelin on the nerves, and that demyelination can result in ascending paralysis. Whoever survives COVID-19 still has lungs that have been immensely affected by the virus. Are the effects irreversible? So the body has different ways of healing in different people. So if someone develops like very severe pneumonia, a lot of times people may have lifelong symptoms. A lot of times people may recover completely. It's very varying from patient to patient, depending on your own body's response to healing. Tocilizumab is being used for management for severe cases. As you said, it binds to the IL-6 receptor and it entered stage 3 trials. Why not every patient? Because it's an immunomodulatory drug. Interleukin-6, like I mentioned, not everyone goes into, hyperinflammatory state. Not everyone develops severe systemic inflammation or that cytokine storm. Like tocilizumab, it's an adjunct therapy. It's not a primary therapy. It's only used if people start developing hyperinflammation. So that's why it's mainly being used in, patients in the hospital, because those patients are developing these hyperinflammatory symptoms. If you have if a patient has like mild COVID-19 and they don't have that hyperinflammation or cytokine storm, there's really no need to give interleukin-6 receptor, antibodies. Like, usse kuch hoga nahi unko. And yeah. If anyone has any other questions, they can ask. Warna, I think it's pretty much done. We're a bit over time this time as well. This was a pretty long tutorial, and hopefully you guys took the points from it, and we'll see in the post quiz, and I'll see if I did a good enough job to get you guys there. But hope there weren't a lot of questions this time, so I don't know if that's a good sign or a bad sign. Are people with allergic rhinitis more prone to develop severe symptoms since their innate system is so active? People with allergic rhinitis do have both innate and adaptive immune responses. There's also a lot of IgEs that are being formed from their Th2 cells. We really don't know enough to know if they are more prone to develop severe symptoms, potentially, but there's a lot of things that are associated as risk factors. Pretty much consider any comorbidity that you have, and it could be a potential risk factor. We really don't know which ones are the most at risk and which ones are the least at risk. At the moment, the one that we know that is the most, according to current research, is cardiovascular disease. But there is potential for anything to result in severe disease. Does some percent of lung function get permanently damaged? So to be able to assess this, we need to have studies, right? We need to have long prospective cohort studies where we follow the patients who developed it and see if they recover and how their lung function recovers. At the moment, I don't know if such studies are being done. I'll look into it. This is actually a question that I didn't think of before, but it's they could get all of their lung function back, or it could be permanently damaged. To know this, we'd have to follow them for a really long time. Your body to heal itself, it can take up to 6 months, years at times even. So you really would have to do a long cohort and kind of see if they recover or not. Okay, so I don't think anyone has any other questions. So I'm gonna open the post test and I'll send the link, and just fill it in. I'm actually very curious to see how you guys do in this quiz, because this was one of those medical oriented lectures. So yep, I'm gonna end the meeting now. Thank you guys for like everyone who came. Okay, bye. How do I stop this recording?